Christina, and today I'm presenting a 63-year-old female with shortness of breath. So as the FNP, I'm going to come to my preceptor and let her know that I believe my patient has one of the two most common reasons for shortness of breath, which are COPD and asthma. So looking at the two to differentiate, I know that COPD has a more chronic progressive onset, literally being defined as symptoms lasting for more than 4 weeks, whereas asthma has a more acute rapid onset, way less than 4 weeks. We're hoping only a couple hours. To take a look at some of the risk factors, COPD's biggest risk factor is smoking. It can also be a risk to the patient if they're exposed to secondhand smoke. Biomass fuels, usually during work, jobs, different situations. If they're exposed to any organic or inorganic dust inhalation, as well as having a history of asthma. So I can take a moment here to just talk about something that these two diseases share, which is the asthma-COPD overlap. This is a condition in which patients are clinically identified for having multiple characteristics of both of these diseases. Yes, you can have a history of asthma, which leads to secondary COPD, but this is a different situation in which the patient has multiple of both symptoms of these diseases and can be diagnosed with this. When we look at the risk factors for asthma, we're looking at this in the context that this patient could be having a potentially life-threatening exacerbation, and we want to scan them for these things so we can prevent potentially life-threatening exacerbations from happening. So one of the biggest risk factors is asking the patient if she's had any previous life-threatening exacerbations. We want to know if she is having any type of asthma attacks in the context of currently taking glucocorticoids, because that would be a red flag. We also want to ask her if she's had more than one admission to the hospital in the past year for asthma exacerbations, as well as 3 or more ED visits in the past year for asthma exacerbations. And we want to also know if she's using more than one canister of short-acting beta agonists per month. Other things that we can ask her would be about her comorbidities. Does she have any cardiovascular diseases? Does she have any chronic lung diseases? We want to know if she has any food allergies, and we want to know if she's not currently taking any glucocorticoids at all. We would also want to ask her if she's cognizant and good at telling when her signs and symptoms of asthma exacerbations are coming on. And we also want to screen these patients to see if they are compliant with their asthma medications, as well as if they have an asthma plan in case that they have an attack. So looking at the signs and symptoms of COPD, the first sign of COPD, if this were to be a new diagnosis that we would look for, is exertional dyspnea. And the 3 cardinal signs would be dyspnea, chronic cough, and sputum production. There comes a host of other symptoms which would look like wheezing. If you listen to their lung sounds, they're going to sound diminished, as well as having crackles at the bases. These patients are going to look hyperinflated in their chest, and with long term, they'll become barrel chested. They're going to feel more comfortable tripoding, sitting forward like that, and this may come along with pursed lip breathing, even accessory muscle use, especially in the neck and the shoulders. You may also see in much later stages even signs of asterixis due to hypercarbia. You may also see distended neck veins, as well as tender and enlarged liver due to right heart failure. And the signs and symptoms for asthma, you're going to see similar things, so breathlessness, the same chest tightness, you might see a cough as well as wheezing. And then severe situations, patients are going to tell you that it's worse while they're lying down. They may not even be able to get out a full sentence when they're talking to you. And then in very severe cases, they may present with agitation due to lack of oxygen. So one of the biggest objective signs and symptoms, as well as tests that we can note in a patient with or having an asthma exacerbation, is to check their peak expiratory flow. So this is an assessment of the severity of airflow limitation. And this is something that all asthmatics should have at home. It's a fairly safe and cheap method of checking the peak expiratory flow. They want to have a pre-established baseline so that when they think they are having an exacerbation, they can use this. And if we note or they note that they are 20% below their established baseline, then we can confirm they're having an exacerbation. So to end with the tests for COPD, the cornerstone of testing COPD is using pulmonary function testing, specifically spirometry. So as the provider, what you want to do is have this patient use the spirometer before and after bronchodilator use, and you're looking for either full or halfway, I guess, recovery of the not being able to move the air. So with patients that do have COPD, they either will not be able to fully recover or they'll be able to partially recover, and this is a confirmation that they have COPD. So I'm going to go in and now assess my patient, and she's going to tell me that her symptoms began this morning after she was dusting her living room. Immediately after she was finished, she started feeling short of breath. She can feel it in her chest and a little bit in her throat. She also tells me that this has only been going on for a couple hours. She came in immediately because she's relatively familiar with feeling this symptom. She tells me that she doesn't feel any pain, but she feels chest tightness and she's having a bit of a cough as well. She's telling me that she feels better when she's tripoding, and she's feeling worse when she exerts herself going up the stairs, or just even walking. Really, she needs to be seated. She's not feeling any radiation of this symptom, but this is constant. She hasn't had any relief from this, so she immediately came in to see us. And she is talking, and she's okay sitting down, no notes of cyanosis, so we know this is a safe situation for right now, but we want to get her treated. And during her health history, she tells me that her mother was an asthmatic, and she was diagnosed in childhood as well. She knew that her trigger was pollen, but she hasn't had an asthma exacerbation in years, so she doesn't fill her glucocorticoid prescription anymore because she hasn't needed to use them, and that this dust exposure is a new trigger for her that she was unaware of. So that concludes that I believe the patient has asthma and not COPD.